Finals SAQ48 myotonic dystrophy. A 35-year-old man presents for a laparoscopic cholecystectomy. He was diagnosed with myotonic dystrophy 10 years ago. A. What is myotonic dystrophy and how is it inherited? MD is a disorder of sodium or chloride channels affecting skeletal, smooth and cardiac muscle, resulting in myotonia, which is delayed relaxation of muscle contraction. Discharge of repetitive action potentials leads to sustained muscle contraction in response to stimulus. There are associated multi-system features. This is a progressive disease with autosomal dominant inheritance. It affects 1 in 8,000 people and may demonstrate anticipation. It usually presents in the second or third decade of life. Life expectancy depends on subtype. B. What are the problems of MD relevant to anesthesia? Airway. Delayed gastric emptying with pharyngeal muscle wasting leads to increased risk of aspiration. Respiratory. Progressive spinal deformity leads to restrictive lung defect. Central and obstructive sleep apnea may be present. Dysphagia, dysmotility and reduced gastric emptying and bulbar palsy leads to increased risk of aspiration. Respiratory insufficiency may be due to atrophy of respiratory muscles, impaired cough, OSA and central respiratory depression. Exaggerated respiratory depressant effect of opioids and IV anesthetics may occur. Cardiovascular. Conduction defects, cardiomyopathy and mitral valve prolapse may be present. Hypotensive and myocardial depressant effects of anesthetic agents may be exaggerated. Neurological. Possibly reduced intelligence. This leads to problems with capacity and consent. Early cataracts affect vision. Myotonia results from shivering or suxamyotonium. Endocrine. There is increased risk of diabetes mellitus, hypothyroidism, adrenal insufficiency, and gonadal atrophy. Pharmacology. Suxamyotonium causes myotonia and may make intubation difficult. Avoid suxamyotonium. Non-depolarizing muscle relaxants may have prolonged action in the presence of muscle wasting. Reversal may cause myotonia. Ideally use short-acting agents such as atracurium and cis-atracurium. GI. Delayed gastric emptying leads to increased risk of reflux and aspiration. Cutaneomusculoskeletal. Muscle wasting may be present. Care with padding. Avoid factors that may precipitate sustained muscular contraction, such as hypothermia, drugs, shivering, and mechanical or electrical muscle stimulation, such as diathermy and neuromuscular blockade monitoring. Additional info. Pregnancy may aggravate the disease. Elective caesarean section is often required due to uterine muscle dysfunction. C. Outline the important aspects of pre-op assessment and intra-op management that are specific to myotonic dystrophy. Airway. Pre-op. Assess safety of airway. Assess history of poor swallow and recurrent aspiration pneumonia. Intra-op. Consider the need for a modified RSI. Respiratory. Pre-op. Assess for evidence of OSA, restrictive lung defect and active pneumonia. Consider chest X-ray, ABG, and formal lung function test. Intra-op. Provide positive pressure ventilation. Cardiovascular. Pre-op. Assess with history and examination for possibility of heart failure associated with cardiomyopathy, arrhythmias, and presence of implantable pacemaker. Pre-op ECG and echocardiogram may be indicated. Intra-op. ECG monitoring to monitor for arrhythmia. Ensure availability of transcutaneous pacing. Consider intra-arterial blood pressure monitoring as patient is prone for hypotension. Neurology. Assess capacity for consent. Patients are sensitive to sedatives, hence use sparingly. Avoid techniques that increases post-op delirium. Endocrine. Pre-op. Serum thyroid function test, glucose and cortisol measurements, followed by appropriate management of derangements. Diabetic management depends on usual diabetic regimen and duration of starvation. Intra-op. Variable rate intravenous insulin infusion if indicated. Regular blood glucose checks. Pharmacology. Pre-op. Avoid sedative pre-medication as the patient may have exaggerated response. Intra-op. Avoid suxamyotonium as this may cause myotonia. rhabdomyolysis and hyperkalemia. Use short-acting neuromuscular blockers or rocuronium with reversal with sugammadex. Do not use nerve stimulator or anticholinesterase as these may provoke muscle contraction. Consider TIVA as inhalational anesthetics have been implicated in rhabdomyolysis and MH-like reactions. If using inhalational maintenance, avoid high concentrations which may affect cardiac contractility and conduction. IV induction agents may cause profound CVS depression. Opioids may cause myotonia. Consider regional anesthesia or analgesia to minimize the use of sedatives and opioids. However, this does not prevent muscle contraction in the area of the block. GI. Pre-op. Provide aspiration prophylaxis in view of increased risk of reflux. Administer antiemetics and mitigate post-op nausea vomiting triggers intra-op. Muscle. Sustained muscular contraction may make intubation, ventilation, and surgery difficult. These do not classically respond to neuromuscular blockade. Quinine and phenytoin have been reported to attenuate problematic sustained contractions, as well as direct infiltration of muscle with local anesthetics. Metabolic. Check electrolytes and correct if necessary pre-op to reduce the risk of intraoperative arrhythmias. Intra-op. Ensure patient is warm to normothermia with forced air warmers and warm fluids. Additional information. Examiner's report. 6.5% pass rate for this question. Prevalence of MD is comparatively high. We are much more likely to encounter MD than malignant hyperthermia. Poorly applied GA causes significant morbidity and mortality. Most candidates have very poor knowledge of this subject, and some confuse myotonia with forms of muscular dystrophy whose prevalence is rarer. Strong candidates scored significantly in excess of pass mark, suggesting their preparation for FRCA was better. Most weak individuals thought incorrectly that suxametonium was contraindicated due to risk of hyperkalemia, and failed to mention the importance of pre-op echocardiography in detecting cardiomyopathy. Categorization of neuromuscular disorders. They may be acquired or hereditary. Regarding acquired neuromuscular disorders, they may be further classified into prejunctional, junctional, or post-junctional pathologies. Examples of prejunctional pathologies include motor neuron disease, multiple sclerosis, Guillain-Barré syndrome, and peripheral neuropathies. Examples of junctional pathologies include MG, Lambert-Eaton, and congenital myasthenic syndrome. Examples of post-junctional acquired pathologies include inflammatory myopathies and critical illness polyneuropathy and myopathy. Examples of prejunctional hereditary pathologies include peripheral neuropathies such as Charcot-Marie-Tooth syndrome and Friedreich's ataxia. Examples of post-junctional hereditary pathologies include muscular dystrophies such as Duchenne, Becker, limb girdle, myotonic dystrophy, facioscapulohumeral and Emery-Dreifuss syndromes, non-dystrophic myotonia such as myotonia congenita, periodic paralysis, central core disease, and myotonia fluctuans, metabolic and mitochondrial disorders such as mitochondrial myopathy and lactate dehydrogenase deficiency. Muscular dystrophies are a collective group of progressive muscle disorders, most often caused by defective or absent glycoproteins in the muscle membrane such as dystrophin. There are more than 30 forms. Inheritance may be X-linked recessive, autosomal recessive, or autosomal dominant. Examples of X-linked recessive inheritance include Duchenne's, Becker's, and scapular-peroneal muscular dystrophy. Examples of autosomal recessive inheritance include most limb girdle types, scapulohumeral muscular dystrophy, congenital and childhood muscular dystrophy. Examples of autosomal dominant inheritance include facioscapulohumeral muscular dystrophy and some oculopharyngeal and ocular muscular dystrophies. Summary of features of some muscular dystrophies. Duchenne muscular dystrophy, usual age at diagnosis 2 to 5 years, mostly affecting males. Most affected muscles include arms, legs, and spine. Loss of gait by 10 years old. Progression by 20 to 30 years old. Respiratory and laryngeal muscles are involved. Cardiac involvement is present for all muscular dystrophies with conduction abnormalities, arrhythmias, dilated cardiomyopathy, and heart failure being possible. Anesthetic considerations as for myotonic dystrophy. Becker's MD is due to partial dystrophin deficit with usual age at diagnosis at late childhood or early adulthood. Most affected muscles as for Duchenne's, progression 30 to 60 years old. Myotonic dystrophy, usual age at diagnosis is 10 to 40 years old. Most affected muscles includes distal, spinal, and respiratory muscles. Progression is slow. Type 1 is more severe. Respiratory and pharyngeal weakness is common. For limb girdle muscular dystrophy, this usually presents in late childhood and early adulthood with proximal muscle weakness. Life expectancy is reduced to middle age. Emery-Dreifuss dystrophy presents in childhood with joint contractures. Life expectancy reduced to middle age. Difficult intubation and regional techniques is expected. Congenital muscular dystrophies present at birth with muscle weakness, hypotony, and contractures. Progression is variable. There is severe restrictive lung disease. Muscular dystrophy. Pre-op and intra-op considerations have been discussed in B and C. For post-op care, consider HDU and ICU for anything other than minor surgery. Chest physiotherapy is vital. Prolonged post-op ileus can occur. Drug considerations in specific neurological disorders. Avoid suxamytonium in motor neuron disease, hemiplegia due to cerebrovascular accident, spinal cord injury, Guillain-Barré syndrome, myotonic and muscular dystrophies, Charcot-Marie-Tooth syndrome, hyperkalemic or hypokalemic periodic paralysis, and critical illness polyneuromyopathy. Suxamytonium dose should be reduced in Lambert-Eaton syndrome and Friedreich's ataxia. Normal doses of suxamytonium may be used in Parkinson's disease, epilepsy, and Creutzfeldt-Jakob disease. Reduce non-depolarizing muscle relaxant dose in motor neuron disease, Guillain-Barré syndrome, myasthenia gravis, Lambert-Eaton syndrome, myotonic and muscular dystrophies, Charcot-Marie-Tooth syndrome, periodic paralysis, and critical illness polyneuromyopathy. Proceed with normal dose for other neuromuscular disorders. Avoid anticholinergics in myasthenia gravis and myotonic dystrophy. Use anticholinergics with caution in Parkinson's disease. Other comments: for motor neuron disease, there may be respiratory compromise. Avoid hyperthermia in multiple sclerosis. Avoid drugs that worsen Parkinsonism in Parkinson's disease. Avoid hypotension and hypocapnia in cerebrovascular disease. Observe for autonomic dysreflexia in spinal cord injury. Avoid drugs that reduce seizure threshold in epilepsy. Hepatic enzyme induction may reduce duration of non-depolarizing muscle relaxants. Autonomic instability may occur in Guillain-Barré syndrome. Avoid drugs that interfere with neuromuscular transmission in myasthenia gravis. Autonomic dysfunction may occur in Lambert-Eaton syndrome. Avoid cold shivering and mechanical and electrical stimulation in myotonic dystrophy. Muscular dystrophy may have respiratory and cardiac compromise. Avoid negative inotropes in Friedreich's ataxia. Reduce thiopental dose in Charcot-Marie-Tooth syndrome. Avoid potassium in hyperkalemic periodic paralysis and avoid prolonged fasting. Maintain normal kalemia and normothermia in hypokalemic periodic paralysis. Dispose airway and surgical instruments following a case of Creutzfeldt-Jakob disease. Consider underlying critical illness in critical illness polyneuromyopathy. The following tables are included here for completion, sourced from the article by Marsh S. et al., Neuromuscular Disorders and Anesthesia in 2011. Duchenne's muscular dystrophy. Introduction. This is the most common muscular dystrophy with 1 in 5,000 incidents. In male newborns, it is rapidly progressive. It is due to alteration in the gene for dystrophin, which is a cytoskeletal protein that contributes to the strength, stability, and functionality of myofibrils. This leads to disruption of the integrity of the sarcolemma, leading to myofibril atrophy, necrosis, and fibrosis. It is primarily an X-linked condition affecting males. Female carriers may be symptomatic with a milder phenotype. Clinical features. Musculoskeletal. There is muscle weakness, typically manifesting between age 2 and 5. Proximal muscles are involved before distal. Lower limb extremities are affected before upper limbs, with waddling gait, asymmetrical lower limb strength, delayed motor milestones, calf hypertrophy, and falls. Affected males are usually wheelchair-bound by the age of 12. There is severe kyphoscoliosis, muscle contractures, and osteoporosis, which is worsened by glucocorticoid use. Cardiovascular manifestations include dilated cardiomyopathy, myocardial degeneration, heart failure, and arrhythmias. Respiratory features include progressive respiratory muscle weakness with mucus plugging, atelectasis, tendency for pneumonia, and restrictive respiratory failure. Management is with aggressive physiotherapy, assisted coughing, assisted ventilation, daytime ventilation, and tracheostomy. Hematology. Vascular smooth muscle and platelet dysfunction may lead to increased blood loss. GI. Esophageal dysmotility and delayed gastric emptying increases the risk of reflux and aspiration. Death occurs from cardiac or respiratory failure, typically in the 20s to 30 years old. Treatment is with physiotherapy, glucocorticoids, and treat as MH susceptible. Pre-op assessment and investigation. Multidisciplinary team involvement to assess risk versus benefit of operation. Respiratory interventions includes involvement of respiratory physician, comprehensive spirometry, measurement of oxygen saturation and assessment of blood or end-tidal carbon dioxide levels, pre-op training with the use of assisted cough techniques, non-invasive ventilation, assess and treat for pneumonia. Cardiovascular. ECG, echocardiography, and cardiology review. Patients may be on antiarrhythmic or anti-failure medications or have implanted cardiac devices. Endocrine. Patients on steroids may be immunocompromised and may have infections that require treatment and may be suffering for other adverse effects of steroids. Hematology. FBC and correct anemia. GI. Aspiration prophylaxis as high risk of aspiration. Muscular. CK levels are often elevated. Baseline level is useful in case of perioperative complications such as rhabdomyolysis. Conduct of anesthesia. Avoid volatile agents and suxametonium as these may cause anesthesia-related rhabdomyolysis. This condition produces signs similar to malignant hyperthermia. Consider TIVA or regional anesthesia. Non-depolarizing neuromuscular blockers are safe, although reduced doses are required. Consider invasive arterial monitoring due to risk of hemodynamic instability. Regional analgesia may minimize opioid use and post-op respi complications. Patients on steroids may require perioperative stress doses. Consider extubating patients directly onto non-invasive ventilation. Extubation should be delayed until secretion load is minimal and oxygen saturations are at baseline on air. Assisted cough techniques should be used post-op to reduce the risk of retained secretions. Other NS considerations as mentioned in myotonic dystrophy wherever applicable. These are my references. Thank you.